Today, we will discuss Chapter 23, page 149 in your text, Trauma, Pulpal, and Periapical Lesions. Radiographic changes due to trauma are a result of fractures or injuries. Fractures of teeth, especially anterior, are very common. The two most common injuries observed on dental radiographs are fractures of facial bones and teeth. Fracture lines are thin, radiolucent lines that are more clinically seen than on X-rays. Crown fractures are easily identified more than root fractures. Fracture lines are demarcated from the region of the bone or tooth separation. Fractures of the mandible and maxilla may be seen in part on periapical film, but larger views, such as of panoramic or extraoral films, are needed for complete visualization. The fractures appear as a radiolucent line, and the radiographs may show displacement of fracture segments. Fractures may affect the crowns and roots of teeth or bones of the maxilla and mandible. Radiographic examination of the injured area is necessary. Crown fractures, most often seen in the anterior regions of the maxilla and mandible. They may involve enamel, enamel and dentin, and pulp. If the pulp chamber is involved, bleeding may result, and endodontic therapy is indicated. A fracture appears as a radiolucent line. This radiograph shows the proximity of the pulp chamber to the fracture. This crown fracture is a missing portion of the crown that is evidenced or apparent. A root fracture is less common than crown fractures, most often in the maxillary central incisor, and crown mobility varies. The closer the root fracture is to the apex, the more stable the crown. If the root fracture is close to the crown, prognosis is poor and an extraction is indicated. A root fracture is also seen as a radiolucent line, but sometimes more difficult to visualize because of the alveolar bone. A tooth with a root fracture exhibits partial or complete sensitivity loss, and if the X-ray beam is parallel with the plane of the fracture, it appears as a sharp radiolucent line. Root fractures enlarge over time. The mandible is fractured more often than any other bone in the body. Treatment for a mandibular fracture is reduction, fixation, or immobilization. A panorex is used and a radiolucent line occurs at the site of the fracture. A jaw fracture can be seen on a PA, but a panorex or extraoral film are needed for complete visualization. A radiolucent line shows the displacement of the fracture segments. Anterior alveolar jaw fractures are the most common of the maxilla. A radiolucent fracture line usually occurs in a horizontal direction. In the middle picture, you can see the mandibular fracture as a thin, radiolucent line. There are two types of injuries that occur: luxation, which is the complete dislocation of a joint, and avulsion, which is the complete displacement of a tooth from the alveolar bone. There are also two types of luxation that we will discuss later: intrusion and extrusion. Intrusion is the displacement of the tooth into the bone. Intrusion is the apparent clinical displacement into the bone. The crown looks shorter than any other tooth, and the entire crown may be displaced into the alveolar bone, which the crown is invisible clinically. Extrusion is the displacement of the tooth pushed out of the bone. Both intrusion and extrusion usually occur in the maxillary central incisors. Just with any movement as a result of injury, there may be permanent or temporary pulpal changes. Avulsion is the complete displacement of a tooth from the alveolar bone. Treatment may include reimplantation of the tooth, and success depends on the time elapsed since the avulsion. This photograph depicts a maxillary central incisor being completely displaced or avulsed from the alveolar bone. Next, we will discuss radiographic changes due to resorption on page 297 in your text. The two types of radiographic changes due to resorption are the natural physiological resorption, in which primary tooth roots are resorbed due to permanent teeth erupting, or a pathological change due to resorption due to infection, trauma, or another unusual condition. In this panorex, you can see a physiological resorption, which is the process seen with normal shedding of primary teeth when the permanent teeth erupts. A pathological resorption is not associated with normal shedding of deciduous teeth. It's observed when teeth are subjected to abnormal stimuli, and it may be internal or external stimuli. This radiograph depicts root resorption following an accident or trauma due to pathological resorption. These pictures show external resorption, which is most often characterized by root end resorption, where roots of teeth appear shorter than normal. External resorption is usually along the periphery of the root surface. It's associated with trauma, chronic inflammation, tumors, and cysts. Usually anterior teeth are affected, and it's not clinically detected, and usually affects the apices of teeth. Internal resorption occurs with crown or root and involves pulp chamber and dentin. It's usually not apparent clinically, and crown may appear pink. May weaken the root and fracture results, and an ovoid radiolucency appears. These radiographs depict internal resorption, which appears as a radiolucent widening of the root canal representing the resorption process taking place from the inside out. These two films, this radiograph depicts internal resorption, which is the radiolucent widening of the root canal, and the clinical picture depicts internal resorption, where the crown may appear pink. There are three radiographic features of pulpal lesions: calcification of the pulp cavity, obliteration of the pulp cavity, and pulp stones. Pulpal sclerosis is a calcification of a chamber and pulp canals associated with age. Obliteration of the cavity is associated with the production of secondary dentin. Pulp stones form small nodules in the dental pulp. There are calcifications found in the pulp chamber or canals of teeth. They have an unknown cause and are asymptomatic, but appear as a round, ovoid, or cylindrical radiopacities in the tooth. There are two radiographic features of periapical lesions. They appear as radiolucencies or radiopacities. This is found on page 296 in your text. Three periapical radiolucencies are periapical granulomas, periapical cyst, and periapical abscess. A histological exam is necessary to determine each type of a periapical lesion. A periapical cyst, also known as radicular cyst, is always associated with a non-vital pulp. An endodontic therapy or extraction is necessary. Another periapical radiolucency is a possible abscess. It clinically is painful and appears to have a pulse. Chronic abscesses are usually asymptomatic as a result of drainage of the infection, called a fistula. Periapical radiolucencies, or cysts, can be well-defined unilocular radiolucencies in the periapical location. Unilocular refers to one compartment. Periapical radiolucencies, such as cysts, can also be multilocular, made up of several compartments. There are three types of periapical radiopacities that we will discuss: condensing osteitis, sclerotic bone, and hypercementosis. Condensing osteitis, known as chronic focal sclerosing osteomyelitis, is a well-circumscribed focal opacity below the apex of a non-vital tooth. Number 1 on the radiograph. Here you can see condensing osteitis, or focal sclerosing osteomyelitis. In this radiograph, labeled as number 1, a well-circumscribed focal opacity below the apex of a non-vital or carious tooth is seen here, called condensing osteitis, or focal sclerosing osteomyelitis. Sclerotic bone is a well-defined focal radiopacity at the apex of a vital, non-carious tooth. It is not attached to the tooth. Labeled as number 1 in the radiograph. Here, it is labeled sclerotic bone. It is a vital tooth, not attached to the tooth in the radiograph. Lastly, we will discuss hypercementosis. It's the excess deposit of cementum on the root surfaces, a result of supereruption, inflammation, or trauma, and does not require treatment. In this radiograph, you can see the excess deposits of cementum on the root of this premolar. This concludes the end of the self-study radiology lecture on trauma, pulpal, and periapical lesions.